You all are being bombarded with a lot of new ideas and therapies, and really what's happening out there in the popular press is a mirror of what's happening in our centers. We're all pretty excited about some of these new therapies, and they all have to do with immune therapy. And actually, the initial immune therapy for leukemias and lymphomas was a bone marrow transplant. As you heard today, when you change the immune system from you to a donor, the donor recognizes your tumor, your leukemia, your lymphoma, and actually can kill it. That involves a very expensive and long process. And the question came down to, can we modify that immune therapy to make it a lot easier so that we could pull it in off the shelf, have you come into the hospital or to the clinic, give you immune cells that are going to be as effective as a transplant, and send you on your way pretty quickly. And I think we're at the verge of doing some of this, and that's what we're going to be spending the next bit of time on. So the use of immune therapy to fight cancer is not new. We just mentioned adoptive immunotherapy from bone marrow transplants, putting a new immune system in. Antibodies, you heard about rituximab. Brentuximab is an antibody drug conjugate for Hodgkin's disease. Vaccines, we do know that HPV vaccine will prevent cervical cancer and probably head and neck cancer in those that have HPV-associated head and neck cancer. Hepatitis B vaccines has significantly dropped the incidence of hepatocellular carcinoma, and now we hope hepatitis C therapy will prevent the development of hepatocellular carcinoma. Dendritic cell vaccines, there's still a low rumbling of this. We actually are continuing to do these at our center. And then engineered T cells and CAR T cells. And there's some subtle differences in the type of cells and what we can and cannot accomplish. Now, the CAR T cells that you've heard about in the media and what you heard about today are all directed against one specific antigen called CD19, which is found on certain leukemias, mostly lymphoid, certain lymphomas, both aggressive, low-grade, and mantle cell lymphoma, but not a lot else. So you're not going to see CAR T cells at this point in time for AML, MDS, multiple myeloma. We can argue the point that there may be selected patients where these might be of value. But it is here, it is now, and it is not new. And there's a history of immunotherapy for hematologic malignancies. And as you can see there, we have antibodies that we've talked about. But it all started in the late 1950s with the first report of an allogeneic bone marrow transplant. And that graft versus host disease, or the effectiveness of the donor cells attacking the patient and the leukemia, was certainly a little bit later finding. But as it's all progressed now, we have multiple antibodies, antibody drug conjugates, and the most recent are the advent of immune cells for therapy. The immune system is actually an organ of your body. It's like your heart, it's like your liver, it's like your kidney, spleen, etc. Your lymphoid system is all over the body, and it provides, in a sense, surveillance for outside invaders, and those can be bacteria, viruses, and in many cases, cancer cells. And the notion is that we all have cancer cells that are forming in our body, and when you develop a cancer, it's because your immune system didn't knock that particular cell out, and it grows without controls like more of the normal cells in your body. The bone marrow plays an important role in the immune system. It's basically where all of our lymphoid cells come from. It also, as you can see here, is where we get our dendritic cells, and our plasma cells. But again, our T cells, which are the blue here, are the cells that we're going to be spending most of the time talking about. It comes from your bone marrow progenitor cell. You're born with these cells, and they are in your bone marrow your entire life. And when you get exposed to an antigen, the T cells activate and help kill viruses and, in some cases, cancer cells. To invoke the immune system, you need a target. When you get a virus, if you get an influenza virus, your T cells are the cells that kill the virus. But the T cells are laying dormant. They're ready to pounce on the virus. But until you get the virus into your body, which is a target, which has a specific antigen expressed on it, and these are usually on the surface of the cells, and these antigens can be targeted by antibodies, which are proteins. You saw the Y protein earlier today, or by cells. And in most cases, they're simultaneously attacking by both antibodies and by cells. Most of the cells are T cells. Most of the antibodies are produced by B cells, which are the two main types of lymphoid cells that you have in your body. This is a schematic of the immune system and designed to show you how complicated this is. But basically what we're looking at here is ultimately down the line effector T cells, which mediate killing of viruses predominantly and cancers, and plasma cells and B cells, which help fight more of the common infections like bacterial infections. Macrophages help present the antigen to the T cells. In other words, when you have a virus or a tumor cell, you have to get the tumor cell to the T cells, and the T cells then produce the immune response. For cancer, T cells do most of the work in preventing and eliminating disease. Not 100%, but these are the cells that do the most, and these are the cells that we infuse into patients. These are the cells that are giving us complete remissions, and these are the cells that may actually be curing some patients with far advanced leukemias. Lymph nodes are where these cells are modulated. So in other words, your T cells produced in the bone marrow go through the lymph nodes and the thymus gland and are activated. This is kind of where they are exposed, if you will, in many cases to the antigens, the virus or what have you. When your nodes and your neck gets sore and you have a sore throat, again, it's where these T cells are starting to generate and modulate the immune system so that they can kill the virus that's in your tissues of your throat and your nose. There's a yin and a yang of the immune system, and this is kind of where we develop the notion that we need immune systems at certain times in our lives, but we don't need it most of the time. If we're attacking cells, we need the cells to attack when we have an abnormality in our body. In other words, if we get a virus, we want the immune cell to be activated. And if we want the immune cells to turn off, we just don't want big lymph nodes in our neck our entire life after getting the first virus. We have regulatory T cells, which help control, here they are. Regulatory T cells are active in turning off the immune system, and immune cells that are exposed to viruses, tumor cells, etc., will actually then cause a downregulation of T cells. When we talk about, for example, you heard about graft versus host disease, it's because the immune cells are increased in significant numbers, and these cells are attacking the body. And in fact, one of the strategies to treat graft versus host disease is to boost the regulatory T cells, or the Treg cells, which indeed do turn down the immunity and reduce the side effects and the toxicity of graft versus host disease. There are regulatory T cells, there are regulatory B cells, there are dendritic cells, and there are other compounds, including things like IDO. The targets for immunotherapy are usually on the cell surface, not always. So as you saw earlier, when you have a T cell that's activated, it attaches to the virus, it attaches to the tumor cells, it attaches to normal tissues, and so the T cells then go to the specific site of abnormality and help to kill or treat the abnormality at that spot. In cancer, the immune system does not recognize the specific antigens on your tumor cells. And if you're not going to recognize, then you're not going to get the cancer cell killing. Some of the strategies then are to move the T cells into close proximity with the tumor cell. Some of them are to change the T cells so that they recognize the cancer cells as they're floating by a little bit differently. And these are the strategies that we're using in 2016 to help kill these cancer cells. The immune responses often require both B and T cells. We talked about this earlier. The T cells are associated with cell immunity, which are the T cells. Activated T cells find the abnormal pathogens and attack them by releasing chemical toxins or by swallowing them up. Whereas antibody-mediated immunity are B cells. They attack by antibodies. Antibodies destroy antigens. And again, in most cases, these work well together. You don't necessarily need to have both, but again, in our normal systems, you have both. And that's why eliminating one or the others of these systems doesn't necessarily mean that your immune system is going to be totally collapsed. So T cells kill cancer cells. So you have an antigen here. The T cell recognizes the antigen. It's associated with a stimulation of the T cell. The immature cytotoxic cell leads to clonal selection. You get activated cytotoxic cells, which then go back and kill the cell. And then you end up with memory cells that last your entire lifetime. So here's a simple example of what happens when we get a vaccine for mumps or measles. The mumps or measles vaccine gets into the body, finds its way to the T cells, immature cytotoxic cells. There's clonal selection. The T cells then are activated. It will kill any abnormality that's associated with the attenuated live vaccine, and at the same time develops a memory cell so that if you ever get exposed to mumps or measles or what have you that you're vaccinating for, these memory cells will say, hey, we're hanging out here. We're just hanging out, but we do have the memory to attack mumps. And so if you bring mumps to us, these cells then lead to activation and will then go and kill the target. Can the immune defect be repaired? So one of the things that we've been doing over the last 10 to 15 years is recognizing that we need to get the tumor antigen to where the immune system is. And many times these antigens are carried by dendritic cells. So when you get a virus in your throat, the virus is not immediately taken up by the lymph node, but there are cells there at the base of your throat called dendritic cells, which pick up the virus and then take that to the lymph node. The lymph node then gets activated, T cells out, the T cells go back to the local tissue and kill the tumor cells. So we know that in many cancers, the dendritic cell was not taking up the antigen. So what we can do then is basically grow these cells in the laboratory for patients, their own dendritic cells, and then inject them directly into the lymph nodes after exposing them in the laboratory to the tumor cells. So this can be done by actual tumor cell lysates or antigens that are unique to the tumor cells. They're called dendritic cell vaccines, and these do occasionally produce immune responses and remissions. The remission rates are not great, but patients can develop life-prolonging remissions in the range of 25 to 30% of the time. Now let's talk about CAR-Ts. There are several platforms and strategies have been developed. So there's three main players. UPenn developed a strategy that's now being expanded by Novartis, which is a drug company. Memorial Sloan Kettering has, and the NCI has as well. And we're working with the NCI-based platform. So NCI is working collaboratively with a company called Kite Pharmaceuticals and developing an anti-CD19 CAR T cells. And the NCI has probably some of the greatest or the most significant data on the use of these agents in human disease. So here's what happens when you develop an anti-CD19 CAR. You have a patient who has a specific disease that has a CD19 on them, You collect their cells, you transfect them, and we'll show you this again in a minute. The patient then receives the cells, and the cells are infused back into the patient. They actually grow and expand in the patient. They target the abnormal cancer cells, the CD19 positive cells, and that's what produces the remissions. So we'll go over this in a bit more detail here. Chimeric antigen receptors are basically formed by merging CD19 with a virus and activating that on a expressing T cell, the CAR, chimeric antigen receptors. So these are cells that clinically target the CD19 on the B cells, which are here. These are the cancer cells, the lymphoma cells, the CLL cells, the ALL cells. So this was initially done at the NCI. It's a phase 1/2 study which designed to investigate the safety, feasibility, and effectiveness of therapy. Patients had to have refractory or recurrent disease that's incurable by standard therapy. And this was an evolving protocol. It was being modified as it was being given. So again, these are CD19, which are on the cell surface of the cells. There's a co-stimulatory CD28 domain and a signaling domain that makes the T cells active when they're exposed to the CD19, which is the fundamental basis of the CAR T cells. So again, patients have their peripheral blood collected like we normally do a peripheral blood stem cell transplant at the laboratories. These are central laboratories. The lymphocytes are collected, enriched. They're activated by anti-CD3 antibodies, the T cells. They're transduced with the CAR gene. This is done through a viral transduction, retroviral or lentiviral. These are then grown in culture for about 7 to 10 days. The product is harvested, cryopreserved, quality controlled, and then sent to the centers for infusion at the bedside. So these are patient-specific cells. These are from you to you. It's a closed system amenable to cGMP operations, which is basically how the FDA requires that we produce these cells and infuse them. And this is, again, now in active and multi-center clinical trials by all of the three platforms. So here's the first 32 patients, 29 are evaluable. This is the largest data set for lymphoma patients. Response rates, again, these are patients that have failed many times transplants, and 76% response rate. About 40% have a complete disappearance of their disease. This was 35% in large cell lymphoma, 57% in CLL, and in indolent lymphomas, 25%. Of the 29 evaluable patients, 16 were still in response, 12 more than a year. 3 patients were retreated. It was mentioned before, retreatment is available if you have a remission that lasts 3 months or more. And interestingly, all 3 of these patients are in remission at 17 to 52 months. This kind of suggests that perhaps we need more than 1 dose of therapy if we're going to expect long-term remissions or potentially cures in these patients. Here's a dramatic response. Here's a patient with, this is a PET scan. And you can see here, this is the liver lesions. These are quite large. This is probably about 5 to 6 centimeters liver lesions and other lymph nodes. And this is a response to the CAR T cells. Single infusion, this is the PET scan before, PET scan after. Complete remissions more than 15 months in a patient who had chemo-refractory primary mediastinal B-cell lymphoma. And if you know anything about these diseases, as we do as physicians, this patient with any other therapy would be unlikely to be alive if they failed an auto transplant. So here's the survival curves. You saw some of these before. Those patients that receive therapy and have minimal residual disease, 78.8 are out at approximately 2 years. And if you just enrolled in the study and were not in MRD, you still had about a 51% chance of being in remission and alive at 10 months. Complete response rate, this is for lymphoid leukemia, 70%, MRD, 60%. Half the patients went on to allogeneic transplant, and for ALL, this looks likely potentially the way to go, that you would get a remission induction with this therapy and then a transplant. And if you get a transplant, your chances of being cured, in other words, no relapse, are down to about 0%. Why is this 51%? Because some of these patients relapse early. Not all of them went on to transplant, only half of them did. But if you go on to transplant, your chances of being successfully salvaged long term. Now, if you would have done a transplant in these patients, just come on in and let's do a transplant, your survival at best would be in the range of 20 to 30%. So here's, we call this a waterfall plot. This is for B-cell malignancies. These are 32 patients. And when you're on a waterfall plot, down below here is the shrinkage of disease. These are complete remissions in green, partial remissions, which are less than 100%, but more than 50%. And this is those patients that progress. So of these, almost everybody responded. A large proportion of patients had a complete disappearance of response, a complete disappearance of disease, and only one patient actually progressed of this therapy. So this is very amazingly effective therapy in patients that otherwise would not respond to any other chemotherapy. So here's a patient with CLL after getting CAR T cells and IL-2 to stimulate the cells after they're infused. And you can see again here that this big rim of lymph nodes here is significantly decreased even at a month, and at 2 years is essentially gone. And when we look at the bone marrow of these patients and look for the CLL cells in the blood, this is a marker for CD19 and CD5, which is a unique constellation of markers for CLL cells before treatment and 13 weeks after therapy. You can see things are totally gone. This is not only effective therapy, but it's very fast. We've seen patients with ALL go into complete remission literally within 2 weeks of therapy, having failed 4 or 5 chemotherapy regimens. And here's eradication of bone marrow lymphoma after CAR T cells. You can see here, this is the CD19. We can actually mark these cells in the bone marrow with the antibody CD19 and CD20, and then after therapy, you can't find the cells anymore. This also eradicates, as was mentioned, some of your normal B cells. But again, our immune system is a bit redundant, and at least as far as we can tell early on, we're not seeing a lot of infectious complications in these patients, although we're watching them very carefully. So this is an ongoing phase 1 and phase 2 trial. We're participating in the phase 2, 72 patients who are getting large cell lymphoma, CAR T cells. These are patients that have to have, at best, progressive disease or stable disease to the most recent chemotherapy. So you have to actually have bad lymphoma, failed therapy to be eligible, or you have to have progression or recurrence less than 12 months after an autologous transplant. You have to be in relatively good shape. So while you have advanced disease, you want to do this relatively early. The primary endpoint is to produce responses, and we're looking at the toxicities, as was also mentioned. So I'll finish up by talking about the T cell receptors, and we're also doing T cell gene modified therapy for solid tumors because these can actually not target just CD19 but other antigens on tumor cells. These are also produced in the laboratory, collected by leukapheresis, and transfected with a TCR gene, a T cell receptor gene, and then cultured in vitro. And this is, again, a little bit different from the CAR T cells. T cell receptor products, again, are potentially a little bit more ubiquitous in their effectiveness and can target molecules not just at the cell surface, but actually below the cell surface. And this is being used for diseases such as malignant melanoma and soon to be kidney cancer, and potentially even down the line, acute myeloid leukemia. Now, before I leave, I do want to make a few comments about the toxicity of CAR Ts. They are very effective. They produce remissions. There are two major complications, as you've seen. The cytokine release syndrome, which are fevers, low blood pressure. Sometimes people need to go on blood pressure sustaining medications, even starting at 24 hours after the infusion of the cells. These are usually transient. They're due to the fact that the cells are so effective in killing that everything just gets disrupted in the body. Chemicals that are secreted by you and your immune system lead to low blood pressure, sometimes leakage of fluid into the lungs, sometimes even transient kidney failure. These are not therapies that can be done on an outpatient basis or likely in a setting other than, in many cases, in ICU with the staff that are available 24 hours a day. The second complication are the CNS toxicities, the brain toxicities that was already mentioned. You see them with blinatumomab, which is a CD19 BiTE cell therapy, these occur starting at 5 to 7 days after transplant. Usually patients get a little confused, a little sluggish. They can actually enter into a coma and sometimes require actually mechanical ventilation for what we call airway protection. We don't want these patients suddenly stop breathing, etc. If you're in a center that has expertise, and most of the academic centers do, in managing these patients, these are therapies that you can get your patients through, but they're scary. They're scary to the patients and their families. They're scary to the docs and the nurses that cover these treatments. And it does take several weeks before patients are ready to go home. But a lot of times before they're ready to go home, they're already in remission. These toxicities, especially the brain toxicities, we don't have a good handle on what causes them and how to ameliorate them. But there's actually some suggestion that perhaps if you get these toxicities, you're going to have a better chance of having a remission. So there is maybe a hidden benefit to this therapy. Patients can get seizures, as was mentioned. They can end up with significant weakness. If they're in a coma for 4 or 5 days, you end up with muscle weakness and may have to go to rehab. But again, we're using these cells in patients that otherwise have no other options for therapy and have a very poor prognosis, usually in the range of 6 months or less. We are seeing dramatic remissions, but not without significant toxicity. Hopefully over time we'll be able to ameliorate the toxicity, and perhaps these therapies should be used in earlier treated patients with less toxicities. It may be that the amount of disease that we have in our patients are leading to the higher rates of toxicity. So Parade Magazine was right. You can get dramatic remissions and potentially long-term remissions with these cells. They're not for the faint of heart. They have toxicities, and they're all very early on in the genesis of therapy. But this has the potential of being truly life-saving therapy for a variety of patients with at least CD19 positive malignancies. We haven't found CARs that are going to be effective for a lot of other diseases, although they're feverishly looking on doing this for other diseases. So stay tuned for that. And I think that's all I have right now. So we've long understood the importance of the immune system in preventing, treating cancer through transplant. We're now developing methodologies where our own T cells can kill and cure our cancers if they can be modified to do so. This therapy of the future is available today and is impressively curing some patients.